We are here with Mr. Jim Horn, who is the lead occupational therapist here at Hope and Believe Outpatient Clinic, and he's going to give us some insight on how the outpatient world works for pediatrics. So I'm going to ask some questions, and he's going to kind of guide us through the process of a pediatric client coming into the clinic. So, Mr. Jim, can you tell us a little bit about the process of a referral?
So we'll either get parent referrals or referrals straight from doctors. If a parent calls in and talks to one of the office staff and we think they need an evaluation or the parent wants an evaluation, we will then send a referral form to the doctor. And they have to sign that form before we do our evaluations. Anyway, so that's kind of how the referral works. We either get them directly from physicians who have clients who come in their office and have developmental delays, and they'll refer them to us, or the parent contacts us and then we contact the doctor.
Okay. And so for the screening process of that, so you get the referral and then you do a typical screening to see if the client really needs the therapy. Is that?
We don't. We evaluate. We don't screen.
Okay. So you do
like occasionally I'll look at a child to see if I think they need an evaluation, but it's informal.
Mm-hmm.
Usually we like to have a referral so
they come straight with the referral.
So that we can evaluate them and
Okay.
So we're not looking at them informally. We can do something formally. But if they do not qualify, then that's fine.
Okay. So you bring. So at that time, what is scheduling like?
Well, one of the office managers schedules the evaluation, so we get the referrals in, and she puts them on people's schedule. If there's 3 disciplines, we try and schedule them all together, not at the same time, but back to back for the parent. Other than that, they just go on somebody's schedule who has space for evaluations.
And that's usually an hour?
Usually, yeah.
An hour for eval.
That's what we set aside for.
Okay. And then, so the client gets evaluated, and then the next step in the process would be for intervention, but that could take a while, right?
So first the evaluation, we get those written up within, I would say, 2 weeks or so. They get sent out to the doctor to be signed, and they get sent to insurance or Medicaid for approval, and then once we get authorization to treat, then we go ahead and schedule them for treatment.
And
our commercial kids are a little easier, so that's Blue Cross Blue Shield, United, anything that's not Medicaid. Those we can usually start pretty quickly because all we need back is the signed eval.
And so those that goes all through the office. The office people work with that.
And then if a parent requests a therapist, we try and schedule them with that therapist. If not, we try and schedule them based on what times they need.
Okay. And I'm sure you have some therapists that are that have special areas for certain types of conditions.
I evaluate most kids under 12 months, just because of the experience factor. We have some new grads, and I have a student here who went to UTMB who does evaluate some infants because she did them when she was here with me. So.
UTMB or?
Sorry. No, UTMB.
UTMB, okay.
She graduated last year in August.
Yay, good school there.
I agree.
Okay. So that's the intervention piece. So during the interventions, just a little bit about your the culture here. What type of intervention work would you say, or what kind of expectations do you have for interventions, for treatment here?
Well, going back to the evaluation, we decide how many times a week and what the necessary amount of therapy would be based on that little tiny window we saw into that child's life. Once we bring them in for treatment, we spend the first week or even 2 or 3 kind of evaluating them a little more and seeing where their specific needs are. Once they know us, once we know them a little better, we're able to kind of hone in on what we think is the most primary impairment they have. A lot of kids coming in, especially children with autism, have a lot of sensory needs that need to be dealt with prior to getting them to sit in a chair and do fine motor work. So we address those needs. We're definitely a clinic that uses the sensory integration frame of reference, and we do all sorts of different therapy, but our clinic is set up to do sensory. And we have an indoor gym, we have an outdoor place, sensory place, and we kind of, to do that therapy in the correct way, you really have to give the children some freedom within that, and I call it child-directed, but not we don't allow them to run everything, but we allow them to direct where their body's seeking out needs and needing what they need sensory-wise. So we do that, we follow them, we give them big doses of sensory stuff. If they're seekers, we give them all the input we can while they're here, in hopes to diminish or decrease the need for that input and have better attention and focus to things more functional, like sitting at a desk and doing fine motor work or anything school activities.
So that's good. So looking at sensory integration as the frame of reference, particularly important for here. As far as models of practice, this is a big question because we teach the models of practice in school, and a lot of times they are kind of in our head as clinicians, but do you have a specific pediatric model of practice that you, if you had to dig deep, that you look at when you're evaluating a client? As far as...
Well, that's interesting. You work here.
Yeah.
So what do you think?
Well...
Models of practice are, after my time. So.
Yeah. Yes. So, and that's a good question, and I think that's a good thing that just asking this because I also teach that class. So trying to figure out if that is something that you think would be something we could even look at bringing into the clinic and discussing to see if that would be important. I feel like it would be good to make it more family-centered. I think that...
Right. You have to base your treatment off something, and you have
right.
to use some sort of compass to follow.
Right. I do think that
there's always good framework to use.
Mm-hmm. And the sensory integration, yes. The models kind of have that. They shape what you're doing, and we do that here. We do look at the client's volition. I think that there's a lot of, with kids, you're looking to see what motivates them because that's the only way you can get them to do anything.
Which is why
that's
said
MOHO.
The
Yeah.
child-directed
yes,
part of it.
That's
so
right.
If you're not doing sensory integration in a child-directed way, meaning you're just sitting a kid on the swing and doing so. Like
right.
I know what Brady wanted, right?
Right.
So I've been with him forever, so I anticipate what he's
right.
needing. But I don't just generally plop kids. They'll go and get on a swing and I'll move it and we'll see how they do on it and what they do on it and
right.
if they want more, if they don't want any more, if they're scared of it or not. And then we grade that model from there.
Right.
So we have the framework of it, but we have to work within that framework. And I will say that oftentimes the framework doesn't apply.
Yeah.
Right.
Sometimes
so
it gets lost in the.
right.
Yeah, it gets lost in it. Yeah.
You have to. I always tell my therapists and students, you need to have plan A, B, C, D, E, and F.
Exactly.
Because A through C is never going to work.
Mm-hmm.
And there is occasion will a little bit, but generally you have to be fluid with pediatrics.
Mm-hmm.
You have to be able to know the theory of what you're being taught.
Right.
And then be able to do that. So if a child goes...
Oops, sorry.
So if a child... Should we keep
better.
going? Or you want
No, that's better. That's fine because it was covering
So
it.
if we go to the ball pit, what can we do in the ball pit that's going to help this child with the goals that we've written for them? How are we going to help them? What can we do? And so you have to have a theory base, and schools get, some schools say, oh, there's too much theory, more practical.
No.
You need the theory before you can get the practical. You have to be able to explain to yourself, to a parent, to a student, to anybody, why you're doing what you're doing. And so when students come here, we spend a lot of time on activity analysis. Why are you doing what you're doing? Why do you want to do that activity with that child? What is that going to work on? If they're sitting there playing Legos, what is that working on? Visual motor and hand strengthening, and you got to motor planning, because you're coming up with a plan and you're putting it together and you're sequencing it out as though you have motor planning. But you have to be able to take the theory that you've been taught and build on that theory. If you can do that, you will be a great therapist and you'll be able to do pediatrics. Because again, pediatrics is fluid. They're going to do something that throws you off. And if all you've had is clinic experience, or, you know, observed this and observed that, you're not going to be able to draw on that theory base that's really important for an occupational therapist to draw on and be able to use to have a successful treatment session. You're never going to see all the treatment. My kids throw stuff at me I haven't ever seen, and I've been doing it for 30 years. I've seen kids that aren't like any other kid I've ever seen.
Right.
Granted, I do have quite a few that look similar, and we treat them in similar ways, but each child is unique, and they're different, and they're magnificent. And so you have to be able to understand that and do that within whatever framework you're using, whatever
lens you're coming in with the lens that you're looking at. That's how I teach the students, as far as the model that you're using is the lens that you're looking through, because some children don't have the capacity to learn to do certain movements or whatever.
Right.
Some things are going to be adapted, right? So that's the lens that you're going to
can't shove a round kid in a square.
That's right. So that's where you
round hole. So
that's that reasoning that they have to come with and be able to choose.
But that's your models.
That's the model.
That's right. You choose the model that best fits fits that child, and then you have to alter it.
Right.
To meet that
and I think we as older, because I didn't have the models either, so I've had to learn them and now teach them, and that's really the best way to learn, actually. But
and when it was us, it was frames of reference.
And the frames of reference came to us before the models of practice did. But after learning the models, it actually makes sense in the whole evaluation piece.
Yeah.
So it would be interesting to do some clinical education out with some of the therapists that didn't have it.
Remember, the sensory system develops really early.
Yep.
And so it's something that we always address with every child we see here. That's my job is the director over OTs, is to get them to understand that, and that we have to look at that piece on every single child we see. Even our children who have neurodevelopmental disorders, that have cerebral palsy and things like that, we have to look at the sensory system. They're not moving, they're not going. So how do we give them that input that they need to mature their systems?
And that's the base, that's the foundationals, that's the way to get to the other systems, yeah. Okay, so that's the intervention and the frames of reference, and then from there, of course, you have your daily documentation. How does the documentation system work?
Daily notes, SOAP notes.
Okay.
The way we do it here is we'll have an S section, and then our O section is basically our goals. So we try and address something on every goal, but sometimes we'll put not addressed at this session, but we go off those goals so that insurance and Medicaid will see that those goals are specifically being addressed in therapy. There's other things we do, and we'll put that in the objective and the assessment section, but for the most part, we're really based on those goals, and everything we do is going to have some relation to that goal that we wrote, if we wrote them the right way.
And what electronic system do y'all use?
We use Fusion.
Fusion, okay. There's so many different ones. And those...
Fusion is very pediatric based.
And that documentation carries over from day to day, which makes it easier to document on. So that's kind of nice.
Forward, and then we just change what we need to.
And so from there, you have reassessments and reevaluations.
Correct.
And how often are those?
Reassessments for kids with Medicaid are twice a year, so every 6 months, and for commercial insurance children, they are a year.
Okay. And so how long do you usually go? Some kids I know we see them all through their age, till they graduate or whatever. But
I see a lot of kids for a long time. There's other kids that come for very short periods. Speech sees them. They roll over kids faster than OTs do. Some PT kids come in just for sports injuries or surgical needs. they've had surgery and they need to rehab. So there may be a limited amount of visits that are utilized with them. But with the sensory system and autism and things like that, we're gonna have these kids for a while. I have a little girl who has a genetic disorder. So I've had her since she was 10 months old, and she's 7 now. So she's always gonna need therapy to keep her functional skills where they need to be at. Because if she doesn't get it, she tends to regress. And so is therapy doing great for her? Yeah, because it's helping her to progress, right? She hasn't hit a flat line yet, like a peak or anything like that. So she's still doing well.
And then the discharge summary is just, it carries on through like the...
Discharge summary comes at the end, and will either discharge because they've met their age levels on their testing, or they are moving, or they're not coming.
Yeah,
Stuff like
yeah. So, and that's another point about outpatient. You want to speak a little bit about that?
Our rule is 85% attendance and 3 no-shows. If you do that, you're put on the waiting list again. Most therapists are really generous with that. They'll give parents their warnings, and you've missed 50% of your visits. We can't do that any longer. We have too many kids waiting. So we try our best to accommodate parents, emergencies, and things that happen with kids and all that stuff, but only to a point can we do that, because our therapists get paid fee for service in outpatient.
That's what I was going to ask. Okay.
They get paid if they see the child. If they don't, they don't.
They don't get paid. And so for a new grad, can you give a little kind of an estimate of what a new grad might expect? I don't know if you can tell us that or not.
Money-wise?
Yeah.
I think it's between 80 and 90
Okay.
a year. It depends with pediatrics, especially in outpatient, it fluctuates.
Okay.
So it's based on, that could be your what you would make with a
Full caseload.
and that's what we pay around here for a caseload of 20, I think it's 26 visits a week.
And a lot of people work 4 days a week, so that's the other thing. You kind of have a little flexibility, right?
We do, but there's a lot of paperwork, and notes take time, so you want it, like a lot of our therapists will work Monday through Thursday and take Friday and write evals or write notes.
Okay. So what other questions? So tell us about you. Tell us now about you. Why did you do what you did and all this good stuff? So we can end on a good note here.
It's an interesting. When I was 17, I babysat a little girl who had cerebral palsy, and I became very interested in her therapy and what she was doing. And so after graduation, I went to USC for a year, and then I left and went and served a mission for my church for 2 years in Ecuador and Colombia. I came back, went to BYU for 2 years, and while I was at BYU, I was working as a PT assistant. Back then, you didn't have to have a license for that. And so I was doing 7 elementary schools in the area, and I would go do all the PT. So then I decided to go to OT school at USC and graduated there in '93 and traveled at first I got a job, Children's Hospital in Salt Lake. Then I did some early intervention. I met my wife who worked at Children's Hospital, my eventual wife. Got married, traveled for 2 years. We went all over the place. New York City, Syracuse, New York, Utah, Wyoming, California, we were everywhere. And then I got a call from some people I'd met while I was working in Syracuse, New York, who went to open up a business. So we opened up there, and I was there for 21 years, and then I left and came to Texas. And after 6 kids and 20 years of owning a business, and now I work for Julie. She's great. So we'll eventually get out on our own. We're looking sometime in the fall of next year, opening up a clinic in Utah.
Awesome.
That's
And
where my kids are.
you have a specialty too, right?
My specialty is sensory integration. I worked at Ayers Clinic all the way through college and in California, and did my first field work there. And
That's pretty awesome.
met Zoe Melo, all those guys that are on all those tests you see, the SIP and Diane Parham, who's on the SPM, was my teacher, my peds teacher. So
So he's pretty famous, y'all.
it was a grand school. We had a good time. They're great. And
Well, thank you very much,
You're
Mr. Jim,
welcome.
for doing all of this for me, and I'm sure we will be seeing you again.
Sure.
Thank you much.
Yep. See ya.
Bye.